My title is in Spanish, but I will be delivering the lecture in English. So I'll be talking about diuretic therapy in acute kidney injury. I have these disclosures that I can discuss with you after if you're interested. So when might we consider using diuretic therapy in patients with acute kidney injury? Here's a list of perhaps some clinical indications or circumstances whereby people will or have used diuretics in the past. One, prevention of acute kidney injury, and I put an asterisk there in part because I'm not sure there's a lot of evidence that's really conclusively proven that use of diuretic therapy can prevent acute kidney injury. In the setting of life-threatening fluid overload, in managing extravascular fluid overload and or fluid accumulation, treating of selected electrolyte disorders, maintaining large volume diuresis in settings such as rhabdomyolysis, mitigating non-renal organ injury, in particular patients who have ascites or other things of that nature. And then importantly, and I'll talk a little bit about this at the end, providing prognostic information about the severity of acute kidney injury. As you know, the mechanism of action of furosemide, the most common diuretic that we're going to use in clinical practice in the setting of acute kidney injury, has this mechanism of action at the thick ascending loop of Henle, where it inhibits the sodium-potassium chloride pump. It's important to note as well, though, that this transporter is also on the surface of macula densa cells, and where it can inhibit further salt and chloride entry into the macula densa, and actually translates into impairing tubular glomerular feedback. So I want to delve into a little data, and perhaps one of the most damaging studies for the reputation of furosemide published to date was this one by Ravi Mehta and colleagues, published in JAMA in 2002. This was an observational study, a secondary analysis of the Picard study database, where they looked at 552 patients who were critically ill, who had acute kidney injury, and were admitted to the intensive care unit. And really the primary intervention or exposure of interest here was whether they had had diuretics prescribed and delivered anytime in the 7 days following a consultation with a nephrologist while in the ICU. And really they looked at death, non-recovery of kidney function, and or a composite of those as well. And what you can see here is basically the results of that analysis. They suggested that the use of diuretic therapy in patients with acute kidney injury in ICU settings was associated with accrued and an adjusted increased odds for mortality. They also did further propensity matched analysis and suggested that this hazard could be as high as 68% higher risk of mortality associated with diuretic use. It also translated into greater risk of non-recovery of function and a composite of those as well. And they did a further sensitivity analysis to say, look, if you looked at anybody who'd ever received a diuretic versus anybody who had never received a diuretic, it seemed to exaggerate that effect estimate, almost a threefold higher risk. However, it's important that you look at this study carefully and try to understand where did they derive this apparent increased hazard for mortality. And these are a couple of the figures in the paper that looks at furosemide dose equivalents. So for each milligram of furosemide delivered, how much urine output did they get per day per se, as a surrogate measure for diuretic responsiveness. Now, overall, the median was around 0.34 milligrams of furosemide per mil of urine that they received. But what you can see is on the graph on the left, looking at creatinine changes over that subsequent 1 week, the dark circles represent the changes in serum creatinine for those that had a high or a low diuretic responsiveness. So they had more than 1 milligram per mil of furosemide delivered to achieve 1 mil of urine output, whereas the triangles represent patients who were diuretic responsive. And you can see clearly that those that were diuretic responsive had lower serum creatinines on every day following nephrology consultation, perhaps an indirect indication that they actually had less severe acute kidney injury. But very importantly, if you look at the graph on the right, this is urine output, and you can see the daily urine volume stratified by diuretic responsiveness. If you look at the dark circles, those are patients who are not diuretic responsive. They're receiving high-dose diuretics on a daily basis, yet are not receiving or not producing any particular urine output, whereas the triangles represent those patients who are diuretic responsive. And it's clearly obvious that there was effect modification in outcome associated with whether patients were diuretic responsive. Now, whether this was a surrogate for less severe acute kidney injury was associated with a lower probability of death or not is unclear, but this is an important finding in the study that needs to be emphasized. And when you looked at the survival curves over time, those patients that did not respond to diuretic therapy, these are the patients that had the worst survival overall. And it's even mentioned in the paper by the authors. The risk was borne largely by patients who were relatively unresponsive to diuretics, and this observation was magnified over time. So this is an important issue to recognize around whether we believe diuretics may have a therapeutic role in acute kidney injury, in part because if patients are not responsive to diuretics, I'm not clear whether we should be continuing to prescribe them on a daily basis for up to a week. These patients probably need another strategy to manage their acute kidney injury. And that's what this study really told me. Since this time, there's been some systematic reviews published. This one was published in the BMJ, fairly high profile, and it was again suggesting, only looking at a few studies, mind you, that use of diuretic therapy in acute kidney injury was associated with an increased risk for mortality. I'm a bit skeptical on that per se. Now, my colleagues with the Best Kidney Study actually tried to replicate Ravi Mehta's study using their large, prospectively collected cohort study of 1,700 critically ill patients with acute kidney injury. And they looked at the same exposure, diuretic therapy following study enrollment, its impact on hospital mortality. And importantly, in this cohort, what they showed was that approximately 60% of all patients who had acute kidney injury, in fact, at some point received furosemide. So we're using this drug very, very commonly in critical care settings with patients with acute kidney injury. But what they showed was that across the three models that they proposed, that there was no statistical evidence of an increased risk for mortality associated with the use of diuretics in acute kidney injury. So this somewhat refutes, if you like, the study by Ravi Mehta. However, there's some caveats about these studies that I think you need to recognize. They're both observational, so there's a risk of residual and confounding. They're both susceptible to selection and information bias. They both enrolled patients with severe and advanced acute kidney injury at inclusion, so there's probably already a cohort of patients there who are less likely to respond to diuretic therapy and had a higher risk of death. There was no data on fluid resuscitation practice, fluid overload, or fluid accumulation. And I think this is really important because fluid has been clearly associated with increased risk for mortality, fluid overload that is, and I'll show you some data on that shortly. There was also no data in either study that looked at diuretic use relative to the onset of acute kidney injury and the variations in practice around its prescription. Now, we followed up this with a systematic review that really tried to focus on patients who were critically ill with acute kidney injury and exposed to diuretic therapy. And we also didn't find evidence of mortality being increased with the use of diuretics, but we did find that use of diuretic therapy can increase urine output, clearly can augment urine output amongst critically ill patients with acute kidney injury. But there was lots of problems with this systematic review, not the systematic review, but the literature that went into the systematic review. Basically, most of the studies were low quality and inadequately reported, often single center, often confounded by co-intervention. So many of these studies also continued to use around-the-clock mannitol, dobutamine, other things like this that might augment kidney function, but we've since learned probably has no role in the management of acute kidney injury. Not all the participants were critically ill. There was prolonged periods of oligoanuria where they were getting exposure to high-dose diuretic therapy, which probably lacks therapeutic efficacy. And interestingly enough, many of the patients were already receiving renal replacement therapy and then concomitantly randomized to receive furosemide therapy. To me, this doesn't really make a lot of sense. If you're providing patients with extracorporeal blood purification and then you're trying to hammer them with diuretics at the same time, it really doesn't make clinical sense. But fluid overload and fluid accumulation have really become apparent as a potential modifier of outcome for this cohort. And this is another study led by Ravi Mehta and his PICARD study database, but one of the first in adults to really show the association between fluid overload, defined as greater than 10% total body fluid excess relative to the weight at the time of ICU admission, and basically showing that whether you received renal replacement therapy or not, greater accumulation of fluid in the ICU seemed to have a particular hazard for increasing your risk of death. In fact, if you looked at fluid overload at the time of initiation of renal replacement therapy, there was about a twofold higher risk of mortality if you had fluid overload than if you did not at the time of initiation of renal replacement therapy. Now, these data are small here, but it's interesting to note that this is some Italian data from the Nefrance study, of which Claudio Ronco was one of the key investigators. And in this study, it was an observational study of around 500, 600 patients, of which around 25-30% developed acute kidney injury in the ICU. And the important thing to note here is that a huge majority of these patients actually received diuretic therapy. So it's very interesting that if you had acute kidney injury, I think the rate was around, I can't quite read it, but it was around 75%. And if you did not have acute kidney injury, it was still between 50 and 60% of patients actually received exposure to diuretics. So again, we're using these therapies very commonly. But what this study also showed in both adjusted and unadjusted and adjusted analysis is that the use of diuretic therapy, right here, seemed to be associated with a decreased hazard for death. So if you were exposed to diuretic therapy, you seemed to have a greater probability of survival, and that's what's shown here in the survival curves, right? The red line represents patients with acute kidney injury exposed to diuretic therapy, whereas the blue line represents patients who were not exposed to diuretic therapy. So here we have some new data suggesting that perhaps the opposite is true, that there may in fact be some protection associated with exposure to diuretics, but it's important for us to perhaps understand why that is. So I'm going to show you a little bit of data that you've probably seen before from the FACT trial. And this was an ARDSNet group trial that looked at 1,000 patients that had acute lung injury and randomized them to two fluid management strategies. One was conservative, where basically all patients in the conservative arm received diuretic therapy and vasoactive support to try to maintain a neutral fluid balance following their initial resuscitation in that first week. Whereas the liberal was the standard of care. And it was clear that the conservative group, after 1 week, basically had a neutral fluid balance, whereas the liberal group, after 1 week, had effectively accumulated around 6 to 7 liters of fluid. And what they found was that there was no significant difference in mortality between these groups, although there was almost a 3% risk reduction amongst those in the conservative arm. Patients who had the conservative fluid management strategy spent less time on a ventilator, spent less time in the ICU, and there was in fact a trend towards a lower utilization of renal replacement therapy amongst those in the conservative fluid strategy, which is very interesting. Now, Morgan Grams, a nephrologist from New York State, she actually looked at the FACT trial and did a sub-study of the 306 or so patients who had acute kidney injury and were randomized to the fluid conservative versus fluid liberal strategy. And in this, she found, very observantly, that in the restrictive or conservative fluid management group, they received less fluid, even amongst those with acute kidney injury. It was much more than the whole study population in general, but you can see the differences here. 0.9 liter per day versus 2.2 liters per day. And after 6 days, 6 liters versus 12 liters. So the conservative strategy received much less fluid. And in multivariate analysis, they showed that a lower fluid balance or fluid accumulation was associated with an improvement in survival. So if you accumulated more fluid in that 6 days and you had acute kidney injury and lung injury in the ICU, you had a higher hazard of death. What's also shown in this study, and she showed it very nicely, is that if you were in the conservative group, thank you, if you're in the conservative group, you received more furosemide. In fact, you can see on average 80 milligrams a day versus 23 in the liberal arm. In fact, people in the liberal arm still receive diuretic therapy. Intensivists love diuretics. We give tons of it to all our patients. But look at the accumulated furosemide over that first week. You can see here 562 milligrams in that first week versus only 159. And what was very interesting is that furosemide exposure in multivariate analysis, increased furosemide exposure was associated with a reduction in the risk of mortality. And in fact, there was no ceiling dose above which dose of diuretic therapy was found to be associated with an increased hazards for death. Now that's very interesting. Now, when they put fluid balance and furosemide in a multivariate model together, they found that the furosemide became non-significant, and then it was largely driven by fluid balance. So the diuretics, in this sense, seemed to exert a favorable impact on survival when it was largely mitigating fluid accumulation. Again, there's been some other studies published, and this is by a group led by Vincent Wu in Taiwan, and they looked at diuretic exposure amongst patients who were receiving renal replacement therapy. Now, before the renal replacement therapy, you can see the mortality rates were no different whether you did or did not receive diuretic therapy. About 75%, pretty high mortality in this group. But what was interesting to me is that still 3/4 of patients in this cohort received diuretics while also receiving renal replacement therapy in those first days. And what's interesting to me is that they suggested that if they had a high cumulative diuretic exposure in the first 3 days while also receiving renal replacement therapy, there seemed to be an increased risk for mortality. So I find that interesting, but I also find it a little bit nonsensical that we would continue to prescribe high-dose diuretic therapy when we're also treating patients with renal replacement therapy. Perhaps I can have a discussion about the rationale for that with people later, but this data would suggest to me if you've decided to start renal replacement therapy in your patients, perhaps just discontinue their diuretic therapy concomitantly. I think that makes clinical sense. What about using diuretic therapy to help wean renal replacement therapy and facilitate recovery of kidney function? This is an older study now, a Dutch study by Peter van der Voort, and it was small, only about 70 patients, but basically it looked at furosemide infusions after discontinuation of renal replacement therapy and its impact on recovery. And while it was shown that furosemide infusions increased urine output and increased urine sodium excretion, it didn't seem to have any bearing on recovery. So I'm not convinced that furosemide in this context will help facilitate recovery, though it may again help you manage fluid. Finally, one of the questions that I had when I was still a trainee was whether a little bit of diuretic exposure could be renal protective in patients who had mild acute kidney injury. And so we designed and completed this pilot randomized controlled trial of critically ill patients with early acute kidney injury admitted to the intensive care unit. And we exposed them to a furosemide bolus infusion versus placebo, started within a minimum of 24 hours. And we really looked at whether this translated into worsening acute kidney injury or not. And we looked at other measures like fluid balance, electrolyte profile, and renal replacement therapy initiation. Oops. And here you can see it's a bit small, but we randomized just over 70 patients into the trial. I won't go into that. Whoops. And a couple of things to note. In our trial, average age was around 60. Most of the patients enrolled were male. There was a lot of comorbidities, but it's important to recognize that in our trial, we did admit a lot of patients that were very sick, right? So these patients had average Apache 2 scores of 25 to 27. The majority of them were treated with mechanical ventilation, and about 2/3 were also concomitantly receiving vasoactive therapy. So this was a sick cohort of patients who developed early acute kidney injury. In terms of some process of care interventions, we found that pre-randomizations, 40% of patients in our trial had already received diuretic therapy. The study treatment duration was about 2 days in furosemide and about 3 days in the placebo group. You can see the cumulative furosemide dose was about 1.6 milligrams per kilo in those receiving furosemide and about 3.2 milligrams per kilo overall for the entire study. And there were similar rates of potassium and magnesium supplementation, as there was some concerns that these patients would be depleted of that. Well, unfortunately, we did not find any significant or statistically significant differences in any of our primary or secondary endpoints. So there's really no impact we found on worsening AKI, on recovery rates, on the utilization of renal replacement therapy, or mortality. What we did show is that furosemide was associated with a higher rate of adverse events amongst those receiving furosemide compared with placebo. And the vast majority of those were minor electrolyte abnormalities related to potassium, chloride, bicarbonate, magnesium, etc. So we would conclude from this study, and here you can see actually some of the biochemical profile of the first week of patients in the trial. You can see there was really not much in the way of statistical differences in creatinine or potassium, but you can appreciate over the course of the trial that sodium levels started to climb amongst patients treated with furosemide compared with placebo, as did the bicarbonate, perhaps causing a little bit of dilutional alkalosis. But we would conclude from this trial that there doesn't seem to be any important signal that a little bit of diuretic exposure early on in acute kidney injury to perhaps preserve kidney function or protect the kidney from oxygen uptake and energy utilization, etc., doesn't seem to be efficacious. Finally, I want to talk a little bit about the use of furosemide and diuretics as a prognostic tool in the ICU. And this was a very interesting trial that looked at something called a furosemide stress test, which is probably a surrogate test to see what kind of renal reserve patients may have. Right? This is a prospective cohort study, 77 patients with early acute kidney injury, and they were basically exposed to high-dose single bolus furosemide therapy. Right, 1 milligram per kilo or 1.5 milligrams per kilo if they'd already received diuretics at some point as a single bolus. And really to measure the response they had to that single bolus to help you prognosticate how severe their acute kidney injury is and perhaps help you inform clinical decision making. So the primary endpoint was progression to stage 3 AKI. And the main results suggested that this furosemide stress test actually was a pretty reasonable tool to predict who would go on to develop stage 3 AKI. In fact, the best operative characteristics we're looking at after the furosemide bolus, a urine output of less than 200 mils at 2 hours after the administration of furosemide seemed to have the highest sensitivity and specificity for predicting who would go on to develop stage 3 AKI. So this may be an important tool that you can use to help clinical decision-making at the bedside about whether you may or may not want to initiate renal replacement therapy. What's interesting is that the furosemide stress test, in fact, seemed to have better operative characteristics than a number of other sort of novel kidney damage biomarkers or tests that we currently are exploring in clinical practice. So the FST, as a dynamic test of renal reserve of the kidney, seemed to have good predictive value. So final thoughts. I think it's important to appreciate diuretics are commonly prescribed in critically ill patients. I think the data on its efficacy and effectiveness are conflicting. However, the question's probably been framed incorrectly in the past, and more recent data are suggesting that the thoughtful use of furosemide targeting largely fluid accumulation and fluid therapy in critically ill patients may have some therapeutic benefit. It's unlikely to be inherently toxic when used appropriately, and I think that's important. I think older studies really suggested that if you use furosemide, it's associated with an increased risk for death. But I think in appropriate circumstances, the use of diuretics and furosemide can be therapeutically beneficial. So diuretics probably have two vital indications in ICU patients with acute kidney injury. One, to manage fluid and fluid accumulation and overload. And then two, perhaps to guide decisions about when to transition to renal support, when to start thinking and preparing for initiation of renal replacement therapy. And that could be through measures such as the furosemide stress test. And finally, and this is my own personal opinion though, it is likely that clinicians, us, the physicians, and not diuretics per se, cause the harm associated with diuretics. And I think that's an important point to take away, that their inappropriate prescription can translate into harm to patients, but it's not the diuretic's fault. And with that, I thank you for your time and be happy to take questions.